All right, here we are. In this video lecture, we are going to discuss the drugs for cardiac dysrhythmias, or oftentimes referred to as cardiac arrhythmias. So I just want to first start with a little discussion on what a dysrhythmia actually is. So dysrhythmia is any cardiac disorder that results in either a rate, a rhythm, or a conduction abnormality. And there's a lot of things that can get somebody into this situation, and these things can be minor or they can be life-threatening. So there's this pretty large continuum in terms of what a dysrhythmia actually is and how it's going to be treated. How the diagnosis is made generally is based on symptoms and also based on electrical readings known as an ECG, or an electrocardiography is the diagnostic procedure that helps to diagnose these things. So I want to first kind of just look at the different types of arrhythmias. And so like I said, there's a whole bunch. Some of the ones that are kind of common in terms you may or may not have heard before. One is a premature ventricular contraction, which is abbreviated as a PVC. And you can see on the slide there that PVCs are significant. Even if someone's not having frequent PVCs, they do carry with them an increased mortality risk. So you can see if someone's having 1 PVC an hour, that increases their mortality risk. If they're having like 10 PVCs per hour, that's an increase in like 20% roughly in that first year. Arrhythmias, some of the more highly lethal ones, which we'll go over in a few minutes, those generally have about an 80% mortality rate in the first year. If they're not treated, and if they do get treated, they still carry about a 50% mortality. So this is kind of a tricky area for treatment, which we'll sort of trying to get into as we go through these drugs. One of the reasons why treating dysrhythmias is so touchy is because the drugs are oftentimes quite toxic. And interestingly, most of the drugs, I'm almost wanting to say all of the drugs that we have to treat dysrhythmia have the ability to either worsen the dysrhythmia or cause an additional dysrhythmia. So it's very tricky. And because of that, there are non-drug interventions that are oftentimes very beneficial, one of which is implantable defibrillation devices that have the ability to, I guess in a sense, they have the ability to kind of take over the automaticity of the heart. All right, so I want to review this picture with you, which is basically looking at the phases of the cardiac action potential. Looking at this picture, you see a couple of different phases, and these are illustrated in your textbook as well. The first notable phase is first, if you look kind of at this sort of slow increase right here, this is the part of this picture that helps us to understand automaticity of the heart, because we have this kind of like slow drift up towards threshold, which is due to the leaky sodium channels. And then we have our fast sodium channels here, which cause rapid depolarization as sodium moves into the cells. As the sodium channels start to close, the calcium channels open. The calcium channels kind of prolong this plateau period, if you will. And while this is happening, sodium channels are closing, calcium channels are opening, positively charged calcium ions move into the cells as well. And then at the same time, potassium channels start to open. So we start to move in a downward direction as the calcium channels close towards the tail end of phase 2 depolarization, the tail end, of this plateau. Then the calcium channel closes, the potassium channels are going to open, and that brings us into phase 3, which is kind of our classic repolarization phase. So the reason why I want to show this to you right now is because our drugs are going to, the three of our different classes of drugs, 3 of our 4 classes, I should say, are going to affect these channels. There's going to be the first group we're going to talk about are the sodium channel blockers. So they're going to have their effect here, slowing depolarization. Then we're going to have the calcium channel blockers, which are going to have their effect in here, which they're going to slow depolarization as well. and kind of act as a cardiac depressant. And then we're going to have our potassium channel blockers here, which are going to sort of prolong the repolarization phase, if you will. All of those drugs are going to have the effect of slowing down the heart, which is what most treatment is aimed at, treating arrhythmias or dysrhythmias that are fast. All right, so what are the symptoms of dysrhythmia? Some are asymptomatic, but if there are symptoms, the symptoms generally are going to be things like dizziness, weakness, fatigue, intolerance to exercise, heart palpitations, shortness of breath, and syncope, which is fainting. So those are symptoms of dysrhythmias. Again, keeping in mind that not all dysrhythmias are going to produce symptoms. The more serious dysrhythmias, however, are going to produce some of these symptoms. And the reason why we worry about treating dysrhythmias or addressing dysrhythmias is because when somebody has a persistent abnormality of rate, rhythm, or conduction, that's going to be associated with an increased risk of stroke, heart failure, and most worrisome, sudden death. So that's what we're kind of looking out for with these drugs. All right. So basically, these drugs are going to be classified based on their type based on where the abnormal impulse is originating and what type of abnormality, rhythm abnormality, is being produced. So basically, we kind of think of this as those that are producing a slow rate and or rhythm abnormality, something that's slowing the heart down. And if you recall, the normal heart rate is somewhere between 60 to 100 beats per minute at a resting state. So a bradycardia would be a slow heart rate, that's going to be less than 60 beats per minute. Traditionally, bradycardias aren't treated unless they are, especially with medications, unless they're symptomatic. So some examples of bradycardia, one is a simple sinus bradycardia, which is just a slow, this is the most common one, by the way. This is a slow rhythm and hardly ever requires treatment. And in some people, it's particularly normal. It's not an abnormal finding at all. Another is something called sinoatrial node dysfunction, or sometimes referred to as sick sinus syndrome. This isn't really common, but basically what's happening here is the SA node is failing to transmit impulses sufficiently. So that means, remember, the SA node is the pacemaker, so the pacemaker is failing to function. And as we know, the pacemaker is called the pacemaker because it generally depolarizes the fastest. So if it's not able to do that, then the whole heart rate and rhythm can become abnormal. So essentially what happens with a sinoatrial node dysfunction is we see a severe bradycardia, so much less than 60 beats per minute. You might be in like the 40 or less kind of category. And the other thing that's kind of characteristic of sinoatrial node dysfunction or sick sinus syndrome is that the heart rate won't increase with sympathetic stimulation, with exercise. It doesn't increase, so the heart rate stays the same, right? Normally, the heart stimulates the sympathetic nervous system, and so when we exercise, we would expect our heart rate to go up. But with sinoatrial node dysfunction, you don't see an elevation in heart rate when somebody is exerting. Another type of bradycardia is something called atrioventricular block, or oftentimes referred to as AV block. And this is a little bit different than what we just talked about in that the AV node is failing to conduct all the impulses or conduct the impulses efficiently. There's different types of AV block. There's first degree, second degree, third degree, which we don't really need to get into right now, but in each one of them, the conduction of the impulses across the AV node is diminished. First degree would be the most minor. Third degree would be a complete block, meaning that no impulses are getting across the AV node and into the AV bundle. So essentially the atria and the ventricles are electrically isolated. So those are some examples of bradycardia. The other side of this, which is kind of where we're going to focus our attention, is tachycardia. So these are abnormal impulses of rate and or rhythm that are increasing the heart rate. So tachycardia is defined as a resting heart rate that's greater than 60 beats per minute. Atrial tachycardia is meaning that there's a rapid firing of the SA node, or there's some kind of an ectopic focus in the atria. Remember, an ectopic focus is any place other than the SA node that's generating a beat. So you can see there that the heart rate in atrial tachycardia is up quite high, somewhere between 160 to 200 beats per minute. Atrial flutter is a very rapid and regular heartbeat, so rapid, regular heartbeat, in which the atria is beating somewhere around, greater than 200, but generally like 250 or 200 to 250, that should say. Sorry, there's a typo there. 200 to 250 times per minute. An even more dangerous situation is something called atrial fibrillation, which is essentially a completely disorganized rhythm. So basically what's happening with a fibrillation is you've got this quivering, in this case atria. The atria is just quivering. It's not actually generating a unified contraction. You can see that this is the most common type of dysrhythmia. And the danger here is blood's going to stay in the atrium. We're going to have a hard time, if you can't get a unified contraction, you're not able to, the atria aren't able to contract and they're not able to move that last little bit. Luckily, the atria or contraction is only responsible for like 20% of ventricular filling. So you're still getting blood in the ventricles, but you're not able to maybe get that last little bit. And because of the abnormality, because of the abnormal wall motion, these people are at a higher risk for blood clotting and therefore strokes. So that's why we worry about that one. Ventricular tachycardia is where we see rapid but regular wide beats with a ventricular rate of about 100 to 200 beats per minute. This one is associated strongly with sudden death. And finally, the worst of all of these is ventricular fibrillation, which is just, again, a complete disorganization of rhythm. You've got a quivering ventricle, which is pumping little or no blood at all. And at this point in time, we consider ventricular fibrillation synonymous with cardiac arrest. So no blood's getting out of that heart. Okay, so that's the most dangerous of these. And again, the most common is probably atrial fibrillation in terms of, atrial fibrillation. And that's going to be the one that we're going to kind of be thinking about in terms of treatment for a lot of these drugs. All right, so the deal with the management on medication for dysrhythmias. One of the things we know about dysrhythmias, anti-arrhythmic agents or anti-dysrhythmic drugs, is they all have the potential to produce pretty serious side effects, and we'll sort of pick and choose which ones we talk about as we go through. The other thing that we have to think about with these drugs is they can all worsen the dysrhythmia or create an additional new dysrhythmia, and in some cases even increase mortality. So you can see that this is sort of a fine line to walk in terms of treatment. Because of this, if someone's got an asymptomatic dysrhythmia, chances are they're not going to be treated with drugs. And the acute ones we're going to probably have to treat, but in many cases, a medication might be bypassed in lieu of something called cardioversion, which I'm going to talk about at the bottom there. This is especially true of ventricular dysrhythmias because the ventricular dysrhythmias really get in the way of cardiac output, right? If your ventricles are contracting so fast, you're not going to be able to get blood out of that heart, and so that's a big problem. Sometimes they do use anti-dysrhythmic agents as a prophylactic measure, meaning to try to stave off serious dysrhythmias, and probably the most common patient population that's going to be approached this way are patients that have had a heart attack or a myocardial infarction. People who have had a heart attack are, because of the ischemic damage to the heart, they're at a much higher risk for dysrhythmias. If you remember in the beginning part of our introduction to the cardiovascular section, we talked about reentry abnormalities being quite common. And a reentry abnormality is oftentimes the type of rhythm issue that we see with, or conduction issue, I should say, that we see with myocardial infarction. So these are people who oftentimes are put on one of these medications prophylactically to minimize the chances of that happening. And we'll talk about which drugs are most likely used for that situation. So because the drugs are so tricky and because they're so potentially dangerous and in many cases not all that effective, at least in terms of correcting for all dysrhythmias, sometimes what's used is practice called cardioversion or defibrillation. So essentially what's happening here is an electric shock is transmitted into the cardiac tissue, and the idea here is that it will temporarily just stop all electrical impulses, both normal and abnormal, and in the hopes that when the conduction system starts up again, it will allow the SA node to kind of pick up the pace. So the SA node will pick up the pace and it will return to what we refer to as a normal sinus rhythm. So that's the benefit of cardioversion or defibrillation. And in some cases, they'll try this before they would use the drugs or in lieu of the drugs, ideally. All right, so these drugs the goal of these drugs is really to basically stop an existing dysrhythmia or prevent an abnormal rhythm from occurring. And they all are going to act by altering the electrophysiology of the heart, because that's what's in charge of what's going on in terms of the conduction of the rate and rhythm in the heart. So the main mechanisms that we're going to focus on are twofold. 3 of the 4 classes that we're going to talk about are going to block ion channels. There's going to be a class of drugs that block sodium channels. There's going to be a class of drugs that block calcium channels. And there's going to be a class of drugs that block potassium channels. And we're going to talk a little bit about each of those and give some examples. And then the other option is to alter autonomic activity. So that's the other option here. So what I'm going to do is I'm going to start by showing you the classifications just really quickly. And then we'll go into each one of these in a little bit more detail. So here's our kind of general classification of the most common antidysrhythmic agents. And there's different ways that people like to talk about these, but this seems to be the most popular way to kind of approach it. So you can see on the left side, there's 4 classes. And these are the ones that we just mentioned. So the sodium channel blockers. Of the sodium channel blockers, there's 3 subclasses. The 1A class, the 1B class, and the 1C class. 1A class, that's where the drugs like quinidine and procanamide and lidocaine, or not lidocaine, pardon me, that's where those are going to come in. And those ones are going to delay repolarization of the heart. They're going to slow down the conduction velocity, and they're going to elongate the duration of the action potential. So all of that's going to have a net effect of slowing down the heart. These seem to be particularly helpful for people who have atrial fibrillation, which is common, premature atrial contractions, also some premature ventricular contractions, and just overall tachycardia. Then we have the 1B. These guys are going to accelerate repolarization, slow conduction velocity, decrease the duration of the action potential. And these are going to be reserved for severe ventricular dysrhythmias. Then we have the 1C. I don't think we're going to talk about any of these directly. They're not going to really affect repolarization, but they're going to slow down the conduction velocity. And again, for severe ventricular dysrhythmias. Then we have our beta blockers. We're familiar with these. We've talked about these before. We'll talk about them again. They come up all over the place when we talk about the cardiovascular system. So remember, the beta-1 receptors are in the heart, and when they're hit, they increase heart rate, and they increase conduction, and they also increase the force of contraction, which is not part of this discussion. So the beta blockers are going to slow conduction velocity. They're going to decrease automaticity of the heart, meaning it's going to slower for the heart to essentially drift up and then fire, reach threshold, and also going to elongate the refractory period, which is the period in which that heart should not be able to be stimulated to beat again. So these seem to be particularly effective kind of across the board. They're used probably more oftentimes prophylactically, which we'll talk about. But they're good for atrial arrhythmias, fast rhythms, and also some ventricular dysrhythmias. Then we've got the drugs that slow down repolarization. Those are traditionally the potassium channel blockers. And they're going to slow repolarization, increase the duration of the action potential, and probably most significantly prolong the refractory period. And these guys have some pretty severe side effects, so they're really limited in their use for pretty severe dysrhythmias, both atrial and ventricular, but they're going to have to be pretty severe. And then finally, our calcium channel blockers. These guys are going to they're going to block calcium channels, of course, and so they're going to slow conduction velocity, decrease the contractility of the heart, which is not always helpful, and prolong the refractory period. So these drugs seem to be particularly helpful for something called paroxysmal supraventricular tachycardia, which is a mouthful. What that means is it happens sometimes, not all the time, and it's above the ventricle, so it's an atrial dysrhythmia. So it's an atrial rhythm, abnormal atrial rhythm, and the atria is going fast. Okay, so those are the calcium channel blockers. So what I want to do now is I want to talk about these independently. I'm going to stop this video at this point just for time, and I'm going to pick it up with the first class, which are the sodium channel blockers.